Hi, this is Michelle Cotty, and today we're talking about suicide prevention and understanding depression and suicide. The objectives for this lecture include looking at statistics and risk factors related to suicide. We're going to examine protective factors and how that affects suicide. We're going to discuss facts and myths and identify what you can do as a nurse to intervene and how to evaluate lethality. In clinical, we would like for you to try to identify safety measures on the unit that are taken to improve patient safety, create a safety plan with an individual if it's appropriate, assess lethality in individuals who have suicidal ideation, and identify the risk and protective factors with that individual, which can impact their risk of attempting suicide. In 2017, the leading causes of death were as follows. First was heart disease, then cancer. Unintentional injuries, you can see, was third. Respiratory diseases, stroke, Alzheimer's, diabetes, flu or pneumonia, kidney disease. And at number 10, we have intentional self-harm or suicide. So suicide is the 10th leading cause of death. And these statistics were taken from 2017, but that's remained pretty consistent over the years. A 2020 data brief showed that suicide is still 2 times higher for non-Hispanic white population when we compared that to the non-Hispanic Black population. So individuals who are white are 2 times more likely to complete suicide. Suicide rates for males are 3.5 to 4.5 times the rate for females. And suicide rates are higher in rural areas when compared to urban counties. And we'll talk about why in a minute. And men who are over the ages of 75, we see the highest suicide rates. It's the second leading cause of death for ages 10 to 34 and the 4th leading cause of death for ages 35 to 54, which is pretty heartbreaking. This is a map from the School of Public Health at Harvard, and they have ranked suicide deaths per 100,000 by states. And you can see that the darker states on this map have the higher suicide rates, and the lighter states have the lower suicide rates. So Ohio is 38. And you can see that the rural states have higher suicide rates per capita. Now, Harvard did an interesting thing. They overlaid this. If you're interested, you can click on the link in the references. They overlaid this map with a map of gun ownership per capita, and it didn't exactly match. There was a lot of overlap, but not exactly, and we'll talk about why. I think that happened in a minute. But rural states have higher suicide rates per capita because they have access to guns, lack of resources. When you think about the space between people, and when people are out on these ranches, they don't have as many hospital systems and doctors' offices to get to. And it's a different lifestyle. When you're working all day and your livelihood depends on things like farming or ranching, you don't always have the time during the day to go into the city for an appointment. In addition, there's a lot of stigma about asking for help. A lot of these individuals are really self-reliant, and so they're very proud of that, as they should be, but that can be a hurdle to seeking mental health resources. So on the last slide, you might have noticed there's a big box that I didn't mention, and in the box it said the words American Indians and Alaska Natives. Suicide disproportionately affects these groups of people, and your book failed to mention it. So I thought to prove a point, I would fail to mention it also on the last slide. But American Indians and Alaska Natives have the highest suicidal rate of all the groups of people that we've talked about. And unfortunately, that was overlooked in the book. So their death rate is 21.5 per 100,000. So they're at the highest rate if you're looking at the numbers on this slide. Why? So why are they the highest rate? Well, one thing that does is it helps explain why gun ownership and suicide rates don't exactly match. And that's these populations, the American Indian and Alaska Native population. So these groups of people have higher suicide rates, and their adolescent rates are heartbreaking, but they have inadequate mental health and substance abuse services. The Indian Health Services is underfunded, and that's a large government organization that helps provide care. There are provider shortages, remote locations. There's a cultural bridge that we failed to, or cultural gap rather, that we have failed to bridge. And so we don't provide culturally competent care. So we're not reaching the people that need reached. As a whole, these groups of people are under enrolled in Medicaid. They are bullied in school, and there's a very high dropout rate and a very low high school graduation rate. The individuals that do stay in school test much lower than their peers on tests. There's a lot of bullying that goes on in school for these individuals, and they have high ACE scores, which we'll talk about later. But ACE scores are adverse childhood events. And so when we look at this map, I just want you to keep in mind that the American Indian and Alaska Native individuals have suicide deaths that are far higher than any other state or area that's listed, and that's at 21.5 per 100,000. Suicide is death caused by injuring oneself with the intent to die. And a suicide attempt is when someone attempts to die but does not die as a result of their actions, so they live. Suicidal ideation is a term that you will hear a lot, and that's usually abbreviated by SI. And that's when an individual thinks about or plans suicide. Now, sometimes these thoughts are really scary and they just pop into someone's head, and that can be very frightening, as you can imagine. So there are 1.3 million 3 million attempts by adults in the United States in the last year. And by the last year, that would have been 2017, because the CDC fact sheet that we are referencing here is from 2018. So out of those 1.3 million attempts, 1.1 million had a plan, but 0.2 did not. They impulsively attempted suicide. Who is at higher risk? Again, individuals who are white, male, veterans, or sexual minority. And by sexual minority, we mean individuals who are not heterosexual. So that includes our transgender community, our gay and lesbian community, and individuals who identify as bisexual or queer. The American Indian and Alaska Native individuals are at the highest risk. And again, our book failed to mention that. Now, how do people usually plan or attempt suicides? Over 50% is firearms. Suffocating or hanging is 25%. Overdose or poisoning, 14%. Cutting, 1.9%, and drowning, 1.1%. Depending on the reference, you will see that approximately 20 veterans take their life daily. So again, another summary. This is a 2016 estimate, and as we know, data is reported backwards. So these always aren't up-to-date numbers. But in 2016, 45,000 people died from suicide, which was one death every 12 minutes. And you can see that many adults think about or attempt suicide. So 9.8 million people seriously thought about suicide. In Ohio in 2018, the Ohio Department of Health stated that 5 people died by suicide every day, and 1 youth dies every 33 hours. In 2018, there were 1,836 suicides in Ohio. And the highest suicide rate were actually adults between the ages of 45 and 64. Males are disproportionately burdened by suicide across the lifespan, and they are 4 times more likely to complete suicide than females. However, females are actually more likely to attempt. The Cincinnati News reported in 2019 that for every one homicide, there are 2 suicides. And that males complete at almost 80%, and females 20%. And again, you can see the racial disparity. And they noted that the elderly white male is at the highest risk. Now, if we are looking at suicide rates by county, the Athens Post had an article in 2019 that showed the Appalachian counties in Ohio make up 9 of the 10 of the highest suicide rates per 100,000 people. And you can see the counties that are considered Appalachia to the right, and then on the map on the left, the counties that are the darkest are the ones that have the highest rates of suicide. When you're thinking about factors that can increase somebody's suicidality, poverty is one of those factors. And so when we think about Appalachia and job loss, economic despair, and kind of a feeling of hopelessness, you can see how those things correlate. In 2015, Penn State did a report on suicides on college campuses and found that there are more than 1,000 annually, and 1 in 10 college students had a plan on how to commit suicide. This is really heartbreaking, and of course, I think we've all heard things at Ohio State recently in the news. I just want to reiterate, we have a full-time counselor here at the college, and the information is located under the student section on the website. Please, if you have any questions, concerns, just need somebody to talk to, know that there are resources here that are available for you. So what are some risk factors? Females, as I said earlier, have higher attempts, and male have higher completions. You're 2 times more likely to attempt suicide if you are unmarried versus married. If you are in the military, if you are a sexual minority, white, history of depression, or previous attempts, health issues, substance use disorder, if you've recently lost a loved one or you're experiencing grief, if there's a family history of suicide, a feeling of hopelessness or despair, really intense emotions, a history of trauma or abuse, if you are American, Indian, or Alaska Native, access to firearms, if you have a lack of resources, unemployment, or financial issues. So pause here for a second. 1 in 5 older individuals are inappropriately prescribed medication, and they are less likely to be treated with therapy. And so keep that in mind when you become a nurse, to maybe advocate for your patient and get them some resources in the community, such as therapy. Older individuals often suffer the loss of a loved one, and they need support just as much as people who are younger. Youth who experience major depressive disorder have a 70% chance of having another episode within 5 years, and as many as a quarter of those individuals seriously consider suicide. Think about all the stress and pressure of social media that adolescents have to endure today that I certainly didn't have to endure when I was younger. So when we think about these risk factors, the book mentions using something to cue your memory. And they mention the word sad persons. So S stands for sex, which would be male. A is age. D is depression. P is previous attempt. E is ethanol abuse. R is rational thinking has been lost. S, social support, which would be a lack of. O, organized plan. N, no spouse. And S, sickness. Thinking back to the adolescent numbers, so 70% of adolescents that experience major depression are going to have a relapse and depressive symptoms within 5 years. So adverse childhood events can drastically impact mental health. Adverse childhood events are measured in something called ACE scores, and there are 3 types of ACEs. One is abuse, physical, emotional, or sexual. One is neglect, physical or emotional neglect. And one is household dysfunction. Are there any incarcerated relatives? Substance abuse? Was your mother or stepmother treated violently? Were your parents divorced or lost to death? And did mental illness run in the family? And so these ACEs are measured in 10 questions. And scores of 4 or more indicate that these individuals will be more likely to have health risks. And we'll look more at this later, but I just wanted to give you an overview and introduce ACE scores. The higher the score, the higher the health risk. So physical and mental health are impacted by childhood trauma. These individuals with higher scores are more likely to experience obesity, diabetes, depression, suicide attempts, have broken bones, stroke, cancer, heart disease. And when it comes to behavior as an adult, they're more likely to be less active, use more nicotine, drugs, or alcohol, and to miss work more. When individuals experience childhood trauma, often the emotions are so strong, and this can result in maladaptive coping techniques as they get older. One of those techniques is cutting or burning or other types of physical self-harm that they do to themselves. So they directly and deliberately hurt their own body without trying to kill themselves. So they are not attempting suicide. And they're using this as a way to escape from the pain that is too difficult to feel. So these individuals can actually feel emotional pain on a deeper level than other people. And in order to deal with that, they use self-harm. So how is it that some individuals have really high ACE scores and they've gone through a lot of really traumatic things in childhood, but they don't have the same outcome? They have more positive outcomes as adults. Well, that's measured in resiliency or protective factors. So prior to the age of 18, you can add up your resiliency scores just like you can add up your ACE scores. And so some of these I really love. One of them is that they had rules in their house that they were expected to keep. And I think that rules are really important. And so I love number 10. I also like number 14. And that is because number 14 says, I believe that life is what you make it. So the locus of control is something that really can kind of determine your outcome. If you believe that everything external, what everybody else does, and the weather, and the new president, if you believe that all of those things control your life and that you have no personal control over your outcome, you're going to be less resilient. If you believe that you have more control as your own person, despite external factors, then you are more resilient. And I personally really love that concept. So protective factors. When people are more responsible, they're less likely to commit suicide. So if they have a spouse or children. Religious and cultural beliefs can be protective. They can also be, unfortunately, risk factors if they've had bad experiences. Life satisfaction can be protective, coping skills, and access to care. So how do we know if a person has enough protective factors to evaluate the lethality, and how do we determine how much concern we should have regarding their suicidal ideation? So first we have to identify the risk factors, and then the protective factors, and then we have to ask them questions. When the suicidal thoughts come, do they linger? Are you able to get rid of them? Do you want them there? Do you have a plan? Do you have behaviors to carry out the plan? Have you purchased a gun? Are you hoarding medicine? And do you intend on going through with this? Once we determine the risk level, then we choose the appropriate intervention to address that level of risk. And then we document how we've assessed it, our rationale, what we've done, and how we're going to follow up with the patient. So one thing that can be uncomfortable for students initially when working in mental health is asking about suicide. So sometimes people think that if you ask somebody about suicide, that they're going to be more likely to now think about suicide. And that is not true. We definitely need to ask the clients, do you have a plan? And what is the plan? And have you attempted suicide before? And you need to be comfortable asking them about this. Usually on the unit, they're asked several times a day. So it's definitely something that they're used to. It's just not something that you're used to talking about yet. So one of the myths about suicide is that people who talk about suicide never commit it. That is absolutely not true. When they're talking about it, they're usually asking for help. People who are suicidal only want to hurt themselves and not others. Well, that's another myth. Sometimes they want to hurt other people and then die with them. Some people feel that there's no way to help somebody who really wants to kill themselves. And again, that is not true. Most people from a biological survival of the fittest standpoint want to live. Sometimes we just need to help instill hope so that they can see past the faulty thinking that might be caused by depression or psychosis or substance abuse and help get them over the hurdle so that they can see that their future is going to be better. Again, if we ask a client about suicide, it will not cause the suicidal individual to commit it. We should never, ever, ever ignore verbal threats of suicide or challenge somebody to carry out the plan. That will not help reduce their behavior. We always want to address it. And people who talk about suicide, this is a myth, are only trying to get attention. No, people who talk about suicide are trying to get help. So again, ask questions. You seem down. Do you feel hopeless? Have you ever thought it would be easier if you were dead? Have you ever considered suicide, and do you have a plan? Ask for help. Ask family and friends, school personnel, people, individuals can go to the emergency room. If you have somebody that seems really unsafe that you can call the police to do a safety check. Individuals can go to their family doctor, community agencies. Churches often can be helpful, and there are local and national hotlines. So if you ever know somebody who seems off to you, ask them, have you ever considered suicide? Do you seem hopeless right now? A safety plan is something that you do with an individual who has suicidal ideation. When we are depressed, our brains play tricks on us and we see things through a different lens, a negative lens. And so we never want to react in a way that we're going to regret when we have this faulty thinking. So before we fall down that hole of depression again, because often it comes back, we want to have a safety plan. What happens if the suicidal thoughts come back? What happens if they get worse? What do I do next? So the first thing is, what are the warning signs? What are your thoughts, images, mood, the situation? Are there certain behaviors you do? I know when I'm not feeling my best, I stop doing laundry. So that might be a warning sign for me. Step 2, what are their internal coping strategies? What are things that they can do to take their mind off problems without contacting somebody else? An example of this might be exercising, like running or deep breathing. Maybe they play songs that they like and dance around the house. Step 3, who are people or social settings that could provide distraction? Maybe they like to go to the coffee shop or go spend time with their family. Step 4, who can I ask for help? What people can I ask for help when I feel this way? Step 5 are to list professionals or agencies that the individual can contact. And step 6 is to make the environment safe. Get rid of guns, get rid of pills, get rid of all of the things that the individual could potentially harm themselves with. So as nurses, there are things that we can do to help prevent suicide. So if you're thinking about primary interventions, we can provide community education and do screenings to identify individuals at risk. I know that I've worked at the Asian Festival with students, and we have done screening tools to individuals to identify depression. And so that would be a primary intervention, screening tools. Secondary intervention would do things like implement suicide precautions for somebody who is in a suicidal crisis and they're having suicidal thoughts. And then tertiary interventions are focusing on providing support and assistance to survivors of a client who completed suicide. So if somebody's family member completed suicide. So what are suicide precautions? Well, if we're thinking about a psychiatric unit, an inpatient unit, if a patient is actively suicidal, we would put them on a 1-to-1. So it would be one staff member that would sit with the patient at all times. We'd make sure we did 15-minute documentation, indicating that they were safe and what they were doing at that moment. We want to make sure the environment's safe. This is a really important thing in the psychiatric unit. So nothing sharp, certain kind of beds. Sometimes the clients can't have sheets. We want to make sure that there's nothing in the room that they can hurt themselves with. And this can be a really long list of things. No plastic bags, definitely no cords, tweezers, nail files, shoelaces, shoes, belts, nothing of that nature. We want to make sure the environment is safe. And then we're giving the patient medications. We want to make sure that they're swallowing their meds and they're not keeping them to overdose on later. One thing that we do not do is we don't restrain patients who are having suicidal thoughts unless they're actively hurting themselves. And this is a very fine line. I will give you an example. I had a patient once in the seclusion room, and the patient was pulling out her hair. Pulling out your hair is not going to cause death. I'm sure that it hurt and it was difficult to watch, but I would not restrain a patient for pulling out her hair. Unfortunately, this particular patient had recently had surgery and next began pulling open her stitches. That is causing her physical harm. And so at that point, we had to restrain her. And so there's a very fine line when it comes to restraint. We always want to keep our patients in the most free situation that we possibly can. So the least amount of restraints, the least amount of restrictions. And so we would not use restraints on somebody simply because they were feeling suicidal. We would only restrain somebody who was actively hurting themselves in a way that would be dangerous to their survival. Pulling out your hair would not be a reason to restrain a patient. So here are some resources. Ohio has a new suicide crisis center that you can text for HOPE to 741-741. And then there's the National Suicide Prevention Lifeline. Here's a list of websites in the area. NAMI is a national organization. They also have local organizations in Ohio. And suicide awareness, suicide prevention websites. The person who completes suicide dies once, and those left behind die 1,000 deaths, trying to relive those terrible moments and understand why. I was unable to find who to credit that quote to, but I think it sums up how the individuals who are left behind feel when they lose someone who has completed suicide. Unfortunately, these families often do not receive the same outpouring of love and support as families who lose a loved one to, say, something like cancer. So So if you know somebody who's experienced this tragedy, talk to them about it. They're changed by the event and often suffer from depression and PTSD. And here is a link that we can provide to survivors. And many of those survivors have found these groups to be invaluable. And that completes our lecture on suicide prevention. Again, we really want you to focus on getting comfortable to talking about patients on the floor, about whether or not they are feeling suicidal, and if they have a plan, and creating safety plans with them. So please review those questions. And here are the references.